Okay, starting the fourth part of the cardio series, we don't have much left, like 2 or 3 parts left. So, multifocal atrial tachycardia. What is it? It can be defined as irregular cardiac rhythm caused by at least 3 different sites in the atria, which may be demonstrated by morphologically distinctive P waves. So, you'll see different kind of P waves. It's more common in elderly patients with chronic lung disease like COPD on ECG, irregular tachycardia with clearly visible P waves preceding each QRS. The P waves are different in shape. So the P waves can have different types of morphology, and you can see in the ECG, P waves are so different. How do you correct it? Management, correction of hypoxia and electrolytic disturbance. Rate limiting calcium channel blockers are often used first line. Cardioversion deoxin are not useful. So just what you have to remember is the morphology of P waves are different, and you correct it by correcting hypoxia or electrolyte disturbance and rate limiting calcium channel blocker. That's all you have to remember for this. Okay, what's next? VT, of course. VT is very important. While a broad complex tachycardia may result from a supraventricular rhythm with aberrant conduction, SVT with white QRS or patient has RVB. The European Resuscitation Council advised that in the periodic situation is assumed and treated as ventricular in origin. So whenever you see broad complex tachycardia, it might be supraventricular, but usually it is taken as a rhythm originating from the ventricles. Okay, there are 2 main types of VT. What are the types? Monomorphic and polymorphic. Monomorphic VT is most commonly caused by MI, and polymorphic, a subtype of polymorphic VT is torsade de Poix, which is precipitated by prolongation of the QT intervals. So QT prolongation is actually dangerous. It may actually eventually lead to torsade de Poix. The cause of a long QT interval are listed later, so we're coming to that later. If a patient has adverse signs such as systolic BP less than 90, chest pain, heart failure, or RET more than 150, then immediate cardioversion is indicated. In the absence of such sign, antiarrhythmics may be used. If this fails, then electrical cardioversion may be needed. So this is an ECG of VT. Okay, features suggesting VT rather than SVT with aberrant conduction. So how do you know if it's VT or SVT? Of course, broad complex, you know that very well. QRS more than 160 milliseconds, and AV dissociation, fusion or capture beats, positive QRS in G leads, marked left axis deviation, history of ischemic heart disease, lack of response to adenosine or cardiac sinus massage, QRS more than 160. These are the signs of VT rather than SVT. So what are these things that are written here? AV dissociation, what does it mean? When P waves is not driving the ventricular activity. Here in this rhythm strip, note that the P waves come after the white QRS. So you see the QRS and then there's the P. Like, no, it's not like it's not connected. Like, P wave is not driving the QRS here. Check was the capture beat. When SNO P wave successfully produce a narrow QRS ventricular contraction. Here's an example of a capture beat. Fusion beats, when SNO will appear like it produced a white QRS. In fact, this is the SNO and ventricular contraction coinciding to come in contract sequence rather than the truly contracted beat. Example of a fusion beat. These are things which are like P and QRS are fused. That's why it's called fusion beats. Okay, what are the drug therapy? You go for amiodarone, ideally administered through a central line. Lidocaine can be used with caution and in severe left ventricular impairment. Prokinamide might be. Verapamil should not be used in those with white QRS tachycardia. Why? Should never be given to a patient with broad complex tachycardia, as it may precipitate ventricular fibrillation in patients with VT. So it might make it worse. If you are not sure if it's VT or SVT with white QRS, adenosine is sometimes given in this situation as a trial. So when you give adenosine and it doesn't work out, that's when you know it's here, lack of response to adenosine. That's when you know it's VT and not SVT. It may slow down rhythm to a degree that you can detect the underlying rhythm. Okay, VT in deoxin toxicity. Treat with lidocaine and phenytoin. Avoid amiodarone, prokinamide. May increase toxicity. DC shock when all measures fail. If drug therapy fails, electrophysiological study, implantable cardiodefibrillator, Still talking about VT. If drug therapy fails, so like what were the main therapy? The therapy was DC shock if there are adverse signs, and then they talked about drug therapy like amiodarone, lidocaine. If it's in VD digoxin toxicity, then avoid amiodarone, give lidocaine or phenytoin. DC shock. Okay, if drug therapy everything fails, then EPS or ICD, particularly indicating patients with significant impaired left ventricular function. Okay, let's move to the other VT, torsade de points. So it means twisting of the points. It's a rare arrhythmia associated with long QT interval. It may rapidly deteriorate into ventricular fibrillation and hence lead to sudden death. On ECG, the QRS changes its shape morphology at certain points in context of white QRS with no PV. So it's kind of like the ventricular version of MAT. Okay. So in this case, it's just the QRS changing its shape, and that one was P wave changing its shape. So basically, what are the risk factors? Heart rate low, congestive heart failure, digoxin, then chronic heart failure, prolonged QT and subclinical long QT, severe alkalosis, recent cardio conversion from AF. How do you correct it? Magnesium sulfate, DC shock. That's what we see. The rest are like correction of the sites. And what's here? Tachycardia and peri-arrest, a situation which is like very much common in critical care units. Okay, the tachycardia and peri-arrest. So the resuscitation Council UK guidelines made very little changes compared to 2010 with regards to peri-arrest. Mainly use of oxygen therapy is not recommended unless the patient is hypoxemic. If it's less than 94%, that's when you give oxygen. Stronger emphasis on the use of antithrombotic therapy in AF and the importance of assessing thromboembolic risk in people with AF. As with all emergencies, assessment starts with basic ABCDE assessment. Patients are classified as being stable or unstable according to the presence of any adverse signs. So, first you see the adverse signs are there or not. Systolic BP less than 90. BP, check the BP. Conscious level is less. LOC, level of consciousness, if you check. Chest pain and heart failure, whether they're there or not. If any of the above adverse signs are present, then synchronized DC shock should be given. Conscious patients require sedation or general anesthesia for cardioversion. So unconscious patient can be given DC shock just like that, and for conscious patient requires sedation or general anesthesia. Assess using the ABCD approach: monitor saturation, give oxygen if hypoxic, monitor ECG and BP, obtain IV access. Okay. Assess using the ABCD approach. So what do you do firstly? Okay, here is the ABCD approach. So assessing the ABCD approach: monitor saturation, give oxygen if hypoxic, monitor ECG, PP, record ECG, obtain IV access, treat any abnormality like electrolyte abnormality. If there is an adverse features, yes, then unstable. Synchronized DC shock, 3 atoms, seek expert help. Give amiodarone over 10 to 20 minutes, 300 milligrams, then repeat shock, then 900 milligrams over 24 hours. So the loading dose at first of amiodarone, then over 24 hours. This is for tachycardia and peri-arrest. If there is no adverse sign, then is QRS narrow or broad? Let's move on there. No adverse signs. QRS. How's the QRS? If it's a broad QRS, what do you think? It's maybe VT. If it's regular, it's VT. Amiodarone 300 milligram about 20 to 60 minutes, and that is the amiodarone thing. If irregular, possibilities include AF with bundle branch block. Broad QRS irregular. AF with bundle branch block as pretest for narrow complex tachycardia. And if known to be SVT with bundle branch block, treat as narrow complex tachycardia. Okay, if it's narrow, then irregular is probable AF. Control rate with beta blocker or DTSM. If in heart failure, consider digoxin or amiodarone. Assess thromboembolic risk and consider anticoagulation for AF. And if it's narrow QRS regular, that's probably paroxysmal SVT. Vagal maneuvers, adenosine, 6 milligram IV bolus. If no effect, then give 12 milligram. No effect, then further 12 milligram. Sinus rhythm achieved, yes, probably re-entry. So paroxysmal SVT, record tolerant ECG is ready to upper street again. Consider antiarrhythmic prophylaxis. If not achieved, probable atrial flutter. So it's very important, like how do you assess tachycardia. If you go through it again, like tachycardia is basically you see for the ABCD approach, then we check for adverse signs. If adverse signs are there, give go for TC shock and also amiodarone 200 milligram 10 to 20 minutes bolus dose, then shock, then give amiodarone 900 milligram over 24 hours. If there is no adverse sign, then that's when you check for the QRS. If it's narrow or broad, if it's less than 0.12 seconds, it's narrow. So what do you do if it's narrow, then you check the rhythm, if it's regular or irregular. Irregular is basically AF. What do you do for AF? It's control the rate, and you can also consider amiodarone digoxin and also consider anticoagulation. If it's regular, go for vagal maneuvers, adenosine. And if sinus rhythm achieved, then it's probably SVT. If it's not, it's probably atrial flutter. If it's broad complex tachycardia, you go for the rhythm. If it's regular, it's VT. Amiodarone same way. If it's known to be SVT with bundle branch block, then this treated as regular narrow complex tachycardia like this. Irregular is AF with bundle branch block. Okay, that was very interesting and a very important topic as well. Bradycardia now. Bradycardia and peri-arrest, they also have some, the Resuscitation Council UK has some points here. Identify the presence of signs indicating hemodynamic compromise, adverse signs. So we've already talked about the adverse signs before. Identify the potential risk of asystole. Heart rate less than 40. Here the adverse sign is a bit different. Heart rate is less than 40. Systolic blood pressure less than 100. Heart failure, ventricular arrhythmias requiring suppression. So what do you do for such a condition? You give atropine. Atropine is the first line treatment in this situation. If this fails to work or there is potential risk of asystole, then transvenous pacing is indicated. So how to give atropine? Consider interim measures like atropine 500 microgram, that is 0.5 milligram IV, repeat to maximum of 3 milligrams. You can give it for 6 times. Or transcutaneous spacing or isoprenolone 5 microgram per minute IV. Adrenaline alternative drugs. So complete heart block with a narrow complex QRS carries the least risk of asystole, as the interventricular junctional pacemaker may provide a hemodynamically acceptable and stable heart rate. Potential risk of asystole. The following indicate a potential risk of asystole, hence the need of treatment with transvenous pacing. Complete heart block, recent asystole, morbid type 2 heart block, symptomatic second degree, ventricular pause more than 3 seconds. Okay. Okay, what are the alternatives that are there? Aminophylline, dopamine, glucagon, this might be used, but atropine is the main thing for bradycardia. Okay, if there is a delay in the provision of transvenous pacing, the following interventions may be used. Atropine for 3 milligram, the same thing. Complete heart block. Okay, what do you do for complete heart block? It's basically the features. What are the features? Syncope, heart failure, regular QRS, bradycardia, wide pulse pressure, JVP, Canon waves in neck, in variable intensity of S1. So some of these things are very important. Like this one, seen a lot of questions in past medicine regarding this. Variable intensity of S1. So trifascicular blocks. These are the things that you have to remember very, very much, like very well. And trifascicular block, what is it? PI interval is grossly prolonged. Fascicular heart block, and there is an RSR complex in P1, that is right bundle branch block, and the left anterior hemiblock is diagnosed when QRS in lead 2 is negative. The combination of RBBB, LAHB, and long PR is known as trifascicular block. So basically, PR is prolonged. There is M pattern in V1, that is right bundle branch block, and then there is left anterior hemiblock, that is QRS is negative in lead 2. So this altogether is trifascicular block. So bifascicular and trifascicular block refer to conduction disturbances below the atrioventricular node, in which 2 or more of the fascicles of the left bundle branch and the right bundle branch are involved. It's been suggested that unexplained syncope in the presence of bifascicular trifascicular block is an indication of permanent pacemaker. Okay, long QT syndrome is an inherited condition associated with it's an inherited condition associated with delayed repolarization of the ventricles. So you see this QT normal one and this prolonged QT. So what is it? What's actually happening? It's just a picture of what's happening in the heart. Associated with delayed repolarization. So you know that it's depolarization and then there's repolarization of the ventricles. So this one is delayed. It's important to recognize that as it may lead to VT and can therefore cause collapse or sudden death. The most common variants of the LQTs are 1 and 2, caused by defects in the alpha subunit of the slow delayed rectifier potassium channel. So basically, blockage of the potassium channel causes prolongation of QT. Okay, since potassium moves out during repolarization, and blockage of the channel delays the moving out from the cardiac cell. A normal corrected QT is less than 440 milliseconds for males and less than 450 for females. So just need to remember this because these are really there in the exams. QT syndrome is a very common topic. Prolonged QT, I mean. Okay, what are the causes of prolonged QT? This is also a very important hot topic. Amiodarone, sotalol, TCAs, chloroquine, terfenadine, quinolones, macrolide like erythromycin, and these are the drugs which can cause prolonged QT, and class 1 antiarrhythmic as well. For congenital diseases, Jervell-Lange-Nielsen syndrome includes deafness and due to an abnormal potassium channel. Romano-Ward syndrome, no deafness. Okay, what are the other causes that can cause QT prolongation? All the hypos, calcium, magnesium, potassium, they all move together always, So hypocalcemia, hypokalemia, hypomagnesemia, acute MI, myocarditis, hypothermia, subarachnoid hemorrhage also can cause a prolonged QT. So all these there. Okay, maybe picked up on routine ECG or following family screening. Long QT1 usually associated with exertional syncope, often swimming. Long QT2 often associated with syncope occurring following emotional stress, for example, exercise or auditory stimuli. Long QT3 often occur at night, rest, paroxysmal episode types of the sudden cardiac death. What do you do for management? Avoid drugs which prolong QT, of course, and other precipitants. Acute first line pharmacological therapy is magnesium IV, bolus, then infusion. Beta blockers, except sotalol, of course, it can cause a prolonged QT, in fact. So beta blockers may be used in ICD in high risk case and left ciliate sympathectomy. Okay, a non-sedating antihistamine and classic cause of prolonged QT in a patient, especially if also taking P5450 enzyme inhibitor. So, for example, patient with a cold takes terfenadine, which is already causing prolonged QT, and erythromycin. Okay, is also there at the same time. Might cause a prolonged QT. The next is arrhythmogenic right ventricular cardiomyopathy. So, a lot of topics in the antiarrhythmia. Okay, arrhythmogenic right ventricular cardiomyopathy. This is the second leading cause of sudden cardiac death. Some specific points that you need to remember. For example, it's autosomal dominant disease, and then the right ventricular myocardium is replaced by the fibrofatty tissue. Okay. Presentation can be palpitation, syncope, sudden cardiac death. This you don't need to know. Okay, ECG, what do you see? Basically, V123 will have T wave inversion, and epsilon wave is found in about 50% of the ARVs. This is an epsilon wave, V1 T inversion you see here, and then there's this epsilon wave, and this is best described as a terminal notch in the Curious complex. Echo changes are often subtle in the early stages, but may show an enlarged hypokinetic right ventricle. So right ventricle is like not really moving much, hypokinetic with thin free wall. And the myocardium is replaced by fibrofatty tissue. So MRI is useful to show fibrofatty tissue. Okay, drugs. Sotalol is the most widely used antiarrhythmic. Catheter ablation to prevent ventricular tachycardia. ICD may be very helpful in this case. Coming to the next part, also very important, WPW syndrome. We have already studied about the delta waves and short PR interval and all that. So it's caused by congenital accessory conducting pathway between the atria and the ventricles, leading to atrioventricular re-entry tachycardia. So there are accessory pathways through which the signals get in again, and then it's causing more contraction. Okay. As the X-ray pathway does not slow conduction, AF can generate rapidly to VF. So that's dangerous. Okay. Prevalence of WPW is 1152. Okay, whatever. Possible ECG features were the short PR interval, very important. White QRS complex with a slurred upstroke. That's the one. Delta wave, slurred upstroke. And axis deviation. It's usually associated with LED. Okay. So you see a positive QRS in lead 1 and the negative QRS in lead 3 and ABF. So that's how you know it's LED. Okay, differentiating between type A and type B. Type A, that is the left-sided pathway, causes right axis deviation and dominant RD in V1, and type B, the right-sided pathway, left axis deviation and no dominant R wave in V1. Okay, what are the associations of WPW? HOCM, mitral valve prolapse, Epstein's anomaly, thyrotoxicosis, second term ASD, all associated. And how do you manage? Of course, you have to get rid of the pathway. Radio frequency ablation of the X-ray pathway. If ablation not available, you go for diltiazem, verapamil, or beta blocker to control symptoms. If above ineffective, propafenone, flecainide. Okay, so all should be avoided if there is existent AFS. Prolonging the refractory period of the AV node may increase the rate of transmission through the X-ray pathway, increasing the ventricular rate and potentially deteriorating into VF. Alright. Cardioversion. Okay. Adenosine should be used with caution for the treatment of AVRT because of potential induction fast AF. AF could induce VF, therefore defibrillator should always be available. So treating this case needs the presence of defibrillator. Okay. If you're using adenosine to treat it, then it may lead to AF and which can lead to VF. So during acute tachycardia, drug therapy could be directed at one of the components of the circuit, the AV node, beta blocker, diltiazem, verapamil, etripamil, or the X-ray pathway. These drugs might act. Drugs acting mainly on the AP should be preferred. Yeah, just target the X-ray pathway instead of other things. In drug refractory antidromic AVRT, amiodarone may also be considered. Okay, CPVT. What's this? Okay, CPVT, catecholaminergic polymorphic ventricular tachycardia. This form of inherited cardiac disease is associated with certain cardiac death. This is inherited as an autosomal dominant fashion. So what you need to remember is basically three things: pathophysiology. Most common cause is a defect in ryanodine receptor RYR2, which is found in the myocardial sarcoplasmic reticulum. This one. Features. What can be the features? Sudden cardiac death. Symptoms develop after 20 years of age. Exercise or emotion induced PVT resulting in syncope. Management beta blocker ICD. Most of them need ICD. Okay, Brugada syndrome. It's a form of inherited cardiovascular disease which may present with sudden cardiac death. So it's dangerous. Inherited AD prevalence is high, moderately high. Brugada syndrome is more common in Asians. So let's see what we present with and how it happens. So in pathophysiology, a large number of variants exist. Around 20 to 40% of cases are caused by mutation in the SCN5A gene, which encodes the myocardial sodium channel protein. So here you see an example of what really happens in Brugada syndrome. We saw in AVRT, like this epsilon wave, T wave inversion in V1 to V3, right? Sorry, ARVC. So that's what we see: T wave inversion and epsilon wave, V1 to 3. So, but here in Brugada syndrome, it's the same place, V1 to 3, but what we see is convex ST elevation, just like that. ST elevation. Partial right bundle branch block, narrow QRS. Changes may be more apparent following flecainide. Adrenaline is used to unmask it in Brugada. Okay, management is what? ICD again. Quinidine is useful in VF storm indicated by fast repeated ICD shocks. Indications for a temporary pacemaker, like when do we use a temporary pacemaker? Symptomatic hemodynamically unstable bradycardia not responding to atropine, that's when you do it. Or post anterior MI type 2 or complete heart block. Trifascicular block, as we've read before, like in long prolonged peer interval with right lateral branch block and left anterior hemi block. Trifascicular block or asymptomatic complete heart block prior to surgical operations. Post inferior MI complete heart block is common and can be managed conservatively if asymptomatic and hemodynamically stable. Okay, what's next? Indications of ICD. So when do you give an ICD? We've already studied by now, like many things which already came up, like long QT syndrome, we've talked about it. HUCM talked about it. Previous cardiac arrest due to VT, we have talked about it. Brugada syndrome, just talked about it. And previous MI with non-sustained VT and 24-hour monitoring and all that. Ejection fraction that less than 35%. Go for it. So we are done with arrhythmia basically. Moving towards the last few portions of cardiology is valvular abnormalities, congenital heart defects, all those. Okay. What do we have here?